Welcome everyone. Thank you so much for taking the time out of your day to come and listen to Dorothy talking about her research in the area of stroke and coaching. It is with great pleasure that I invite Dr. Dorothy Kessler here with us today from the Queen's University in Kingston, Ontario, yes. Canada. She's here with us for a few days, and she's delighted that so many of you could take the time to come and listen to her work today. Without further ado, Dorothy, I'll hand it over to you.
Thanks. So yes, thank you all for coming to listen to me. I feel very honored to have such a big sort of group here and across the sites. So I'm going to talk about my research, most of it done through my PhD, but really around sort of what I've learned and some of my thoughts around enhancing participation for people who've experienced stroke. And I will refer to people with stroke as stroke survivors. I think I'm comfortable with the language because I know my colleagues who are stroke survivors use that term. So, and it simplifies things somewhat. So just to get this going. Oh, at your computer. No? It's not moving ahead.
Perhaps just click on the PowerPoint one time with the mouse and you should be fine.
Oh, yeah. Okay, join her.
There we go. Okay. So just to talk about, to give you an overview of what I'm going to talk about today, then I'm going to just touch briefly on participation. What is it? Prevalence. I'm going to go through what we know from the literature so far about enhancing participation following stroke. And then I'm going to go a bit more detail into occupational performance coaching used with stroke survivors and what I've discovered through my research in that area. So just in terms of prevalence of stroke, you're probably fairly familiar with this, but within New Zealand then there's approximately 60,000 stroke survivors, people living with stroke. In Canada, compared population-wise, it's a similar percentage, but around 740,000 people living with stroke. So it's not insignificant, the number of people. And of these people, then about 60% will experience problems with basic daily activities, might be getting washed, dressed, getting around. But as high as 80% will experience problems with participation, with engaging in those activities that they define as meaningful and important to them. And this can include work, volunteer work, home management, their leisure activities, things that they really want to do and take part in. So I think there's been a fair bit of research that's tried to sort of pinpoint who's going to experience these problems. And so I'm just going to give you a little bit of the background, but keeping in mind that if it's 80% of people who experience stroke, it's almost everyone you see are going to run into some sort of challenges. So in a qualitative study that looked at people over 15 years and looked at their social and leisure participation, some of the characteristics were the personal characteristics, so their personal situation, those types of things. Having social support and supports for their activities. If they needed help with someone, they're more likely to have challenges. Having access to services and also just access to environments, right? Sort of the accessibility of an environment that would allow them to attend activities. And importantly, their perception of their capacity or their ability to take part in activities. So I think keep that in the back of your mind, because I think really what they perceive as they're capable of is really going to influence what people do. And we know that even people who have mild strokes or mild impairment following stroke experience problems with participation.
Have I interrupted it? Sorry.
Oh. Try again. There we go. Oops. Okay. So just to make sure we're all on the same page in terms of what is participation, the World Health Organization defines that as involvement in a life situation, and they have a number of categories that you could put these types of activities into, from your basic self-care type activities to your relationships with others, to working, to communicating, so a wide variety of categories. What I think is more interesting, oops, I think it was me. is really how stroke survivors themselves
be as well a recording of today's lecture, and they'll be available on the University of Otago website within the Rehabilitation Teaching and Research Unit, which is where I work, Fiona Graham, and I forgot to introduce myself at the start. Dorothy, what slide did you?
Yeah, there.
Yes.
Interesting.
As you
Yeah, I'm not sure whether that picture's pushed up, but anyway, we'll go with it.
Okay, do you want me to?
No, I think we'll just go with it.
We just carry on.
Yeah. So, as I was saying, so what's more interesting for me is how stroke survivors themselves define participation. So I'm just pulling from a couple of studies in how they describe what was important to them and how they define participation. So in one, and these are qualitative studies, they described as being actively involved, making meaningful choices, and being me. So doing things that really define them, that are important, and describe who they are as a person is critical. And as well, sort of goals around participation is being part of community and having access to opportunities and supports. So what we can see that in the World Health Organization, as these broad categories, what's really important to people are those individualized things that really define who they are and how they see themselves as a person. So there's not going to be a global, this is what it is for everyone, but each person will have their own definition. So looking at from the literature perspective, how can we improve participation? So I'm going to share with you just some different levels of research. So first, looking at qualitative studies that looked at the process of re-engagement in valued activities. And this study followed people, this first study followed people over 24 months and looked at how they gradually got back to things that were important to them. And the process involved really having social connection, and that is having a sense of belonging, a feeling of reciprocity, so doing one's share, sort of a bit of that give and take that we all experience in our lives, and then having support as well. And if those things were in place, then people were willing to take risks and take chances and try out things. And it also gave them hope. So through this process, they learned to adapt their approach to activities, and resulted in kind of an adapted form of engagement. So they learned to get back to do things, and through the process, they developed some better confidence in themselves. However, if people perceive challenges in participation related to age as opposed to being related to their experience of stroke, they tended to become disengaged. So this revolves more around their beliefs about aging and what they expect from aging. So just something to keep in mind. I think we all have different approaches, and we would probably know from our clients have different approaches to aging. So keeping that in mind as we work with them. So another study that was a meta-synthesis, so a synthesis of qualitative literature that they Reed and colleagues were really trying to inform what are the important components of services if we're developing services for people with strokes. What are those important components that these services need to include? And certainly one of them is those individual goals, so goals that are really relevant to the person. Again, support comes up as an important component that programs need to have, as well as guidance, and guidance to help people overcome barriers, not just physical barriers, but also psychosocial type barriers and economics, and so financial barriers. And certainly we know that people who are struggling more financially are going to face more challenges engaging in different activities. And then programs should be designed to enhance confidence and that sense of self-efficacy, so that perception that you're capable. And this can be done through positive social interactions, but I also believe through sort of just that process of re-engaging and trying things out. If we look at the literature that's a bit more maybe epidemiological along with the qualitative research, we're starting to see similar themes. So really, there's certain factors that people experience following stroke that inhibit their participation, and that we can change as healthcare providers. We can some way influence these through, might be different disciplines, but we have a way to impact these. And so one of them is the accessibility of the environment. And this can be both the physical environment, but also cultural, social environments, institutional environments that may get in the way of participation. As well, we can have there's ways to impact affect. So I think detecting depression, screening for depression, and treating depression are important aspects of this. So really being aware of the affect of people following stroke and ways that we can impact on that. Functional ability through adaptation, through promoting recovery. Having goals, so again, goals is coming up, support's coming up. Having knowledge and access to information. So people following stroke are often seeking knowledge. They want the information, they want to understand their stroke, so helping them get the information that they need. Developing self-efficacy, so building their confidence, and support. So all of these things, I'm going to get you to start to think about in your day-to-day practice. How can we start to incorporate and address some of these things that we can change and help people face challenges down the road? So when we look more at the harder evidence in terms of intervention studies, then the evidence is building. This is an area where we have lots of room to grow. And there certainly have been a number of studies done on a variety of different types of interventions, and I've kind of categorized them into sort of four areas. They could probably be a bit of overlap between, but certainly there's interventions out there that really are focused around goals. And this can be like community-based occupational therapy or other rehab that is centered on goals set up by the client. There's neurofunctional treatment. Co-op is, I don't know if that's common here, but cognitive orientation to occupational performance is being tested with stroke and found to be quite effective. And then I'm going to talk about occupational performance coaching. So these ones are centered really around the individual's goals. There are psychosocial and cognitive behavioral approaches, and these have primarily been geared to treating depression and mood, and have measured participation outcomes as a secondary outcome to the main focus of the intervention. There have been interventions that focus specifically on leisure and instrumental activities of daily living, and these have typically been sort of from within the occupational therapy sort of field, looking at testing those interventions. And then there's really a wide variety of programs and groups out there in the community that have been evaluated to look at how they can improve participation. So today there's a lot of approaches. Findings from this research have been limited, so there's been some success, but often there may have been really shown from an evidence point of view to have no impact or to have not a lasting impact.
What's ECM therapy?
Sorry, self-management. Sorry about that. Is there any others I didn't? So MI is motivational interviewing, and CBT is cognitive behavioral therapy. So how can we improve participation based on the intervention studies? Then from among these studies, there are a few components that kind of emerge to be present, or some of them present, in the most promising studies. And so you're going to start to see the pattern here, the presence of goals. So having goals that are personally selected, or at least including activities, if it's a group community program, that are personally meaningful to participants. Including that active education, so having the knowledge or engaging them in the process of learning and problem solving and finding solutions is an important component. Providing support, and this can be various types of support, but the literature is showing that really the most important type of support is that emotional support. So really being there for the person and helping them through encouragement and socially supporting them. and then focusing on building self-efficacy or capacity and confidence. So I'm going to just take you back a step then and just tell you a little bit about my journey to where I got where I am and how I sort of came across occupational performance coaching. So I worked as an occupational therapist in inpatient stroke rehabilitation for 20 years. And during that time, probably participation didn't cross my mind very much. The focus, and I'm not sure if it's similar here, but the focus in Canada through my work in inpatient rehab was really on getting people ready to get home. So what do they need to do to get home? They need to get washed, get dressed, they might need to cook, they might need a wheelchair, but sort of meeting all those needs, as well as really focusing on recovery of impairments. So helping them learn to recover their use of arm, cognition, perception, those kind of things. So really focusing on those components. And every now and then I would think about, well, I wonder how they do when they get home. Like, I wonder how they're going to manage. But it wasn't really a focus of my thought process earlier on. I started to get to think about this and got involved in a small research project that looked at home-based occupational or community-based occupational therapy for people following stroke, and really focused on their individual goals. And this was at a time in Canada, at least before there was any or any widespread any outpatient therapy services. So at that point we were saying, people need something, and when they go home, can we try something out? So we looked at just providing OT, and what we found from that small study was that although they didn't maybe rate their performance of their goals higher, they were more satisfied with their goals and with what they were able to do. As I sort of moved on and decided to go back to school and do my master's, I looked at, I was really interested in those people who describe themselves as doing well following stroke. So I interviewed people who describe themselves as living successfully with stroke. There's been a lot of work on problems people encounter, so I wanted to kind of take the flip side. And I used a transformative learning lens, which is really looking at, do people learn through changing how they interpret their life situations? How do they change their beliefs, their knowledge, to sort of come to a different way of viewing the world? And what I found from that study was that those that did well went through this process of a trigger, which was a stroke. It's kind of a traumatic event for most people. And through having a good support network and getting the knowledge they needed, the people that I interviewed actually sought out knowledge. They were really actively engaged in their recovery and finding information. And they were empowered to make choices and take action and to follow through. So in this way, they were able to, they were in some ways their own therapists in terms of guiding their own recovery. And as I sort of thought about this work and what an intervention could look like, I came across coaching. And I was starting into my PhD, and Dr. Graham was in Canada and presenting at the Canadian Occupational Therapy conference and presented on occupational performance coaching. And to me, it was really hit as, oh, this might be a really good fit for people following stroke. So going back to all the literature that I just talked about and the themes emerging from them, and the components of promising interventions, for me, when I looked at this and what the components of occupational performance coaching were, I really saw that there was a really nice fit in terms of the different components. So the type of support, the information provision, sharing, having a process of problem solving or looking for solutions, and just building competency throughout the process. So to me, I just found like this was a fantastic fit, and it was something to be tested. So I'm going to take a little step back, and I apologize because I know that that this audience is not just occupational therapists, and I think that we, as other rehab professionals, you can really think about coaching as being relevant to almost any area of rehabilitation. In OT, coaching has been defined as an enablement skill. So in occupational therapy, in Canada, there's the Canadian sort of what we call the Bible of OT, defined 10 enabling skills, and coaching is one of them that is a critical one. And in that definition of coaching in occupational therapists, and I think across the coaching world, it's really, coaching is focused on being asset-based or solution-focused. So it's really looking on building on people's strengths, identifying their strengths, not focusing on problems, but building on their strengths. And taking them or helping them to be empowered to take responsibility for finding their goals, determining what they want to do, and collaborating with them to take steps to work towards their goals. So just a bit of background then about occupational performance coaching. So it was developed by Dr. Graham, and she has tested it with parents of children who have experienced occupational performance challenges and found it to be quite successful with these people. And so the goal is really to improve their occupational performance or their participation in activities that are important and valuable to them, while developing their self-efficacy, their confidence, helping them develop strategies and skills to apply to new challenges as they move forward. So when I looked at this intervention and its applicability for stroke, I looked at it with that lens and had a couple of adaptations. And these were really in the area of maybe broadening how we think about support in the initial occupational performance coaching. When it was developed, support was really focused around the family. And for older adults, that family might be broader. It can be friends, more of their social network to be considered in terms of the conceptualization of when we think of support. But probably more importantly was in occupational performance coaching, how it was used with parents of children, the focus of change was on changing the environment and or adapting the task to enhance performance or participation. And we know following stroke that people continue to recover for several months and sometimes for years in different areas. So I felt that we had to include, in terms of the intervention, consideration of that potential of the person to have ongoing recovery in terms of how they sought out solutions to reach their goals. So these are the domains of occupational performance coaching for stroke. And if you're going to be reading more, following this on occupational performance coaching afterwards, you may find these presented differently. And I think Fiona has had them evolve. I've decided to keep this structure because as you go through the presentation and findings from my research, it fits within these domains. So really talking about as emotional support, being there for encouraging people, listening is really critical, to hear people, to hear what they have to say and hear their resourcefulness. And part of that emotional support is also being non-judgmental. And sometimes as therapists, we have our professional upbringing in the background that we're always, I think, we have in the back of our mind this turned on, this evaluation of, okay, what's going to happen next is, and the safety thing that probably comes up often. So just trying to put that in the background a bit and trust that that you're going to be able to help guide people, that people will make decisions that are going to work for them, and being non-judgmental in what they decide to do. In terms of individualized education, that is helping. This is really not a one-way, but it's a bi-directional exchange of information, and related primarily for stroke to the information they need related to their stroke and their health condition, but also around strategies and what to expect going forward, helping them to, sharing information to get an understanding of their situation and what's impacting on it. And then having a goal-focused problem-solving strategy. So this is a strategy of that. So the typical problem-solving approach is goal, plan, do, check, but it's really focused on the goal. So it's helping them work through that process. So when I use this in my research, just in terms of process, the first process was goal setting. And what I chose to use was a personal project analysis framework. And this is a framework that comes more from psychology, but the idea is to get people to think about projects that they would like to do, and these can be, so projects are defined as sort of activities that can be ongoing, they can be short-term, they can be long-term. So if you think in your life you may have several projects going on, one might be to decrease clutter in your house, or it might be to plan a trip or invite people over for dinner. So different things can be your projects. And I chose to use that because I wanted to try and get people to think beyond recovery. So for the people with stroke, a lot of the focus does tend to be, when you ask what are your goals, is I want to improve my balance, I want to improve my arm, I want to, really looking at the impairment level. And I wanted to help stretch them beyond that impairment level to think more at a participation level for their goals. And then once they'd established goals, then going through this problem-solving framework of so analyzing where you're at now. So there's a collaborative performance analysis process that looks at the person, their environment, the task or their goal they want to complete, and trying to find solutions, looking for solutions to move forward toward the goal. And through this process, and the idea is to get people to envision where they want to be, what they would like their participation to look like, and then what are the steps needed to get there, and to plan specific actions to get there. So you will plan the action, you come back, discuss, sort of do an evaluation of how it went, looking at it from what happened, and not from if something didn't happen, that it's a failure, but what we can learn from that. So really taking that strength-based, positive type of approach to get people to learn through their experiences. So in terms of sort of my work in testing OPC for stroke, I did initially just a very small pilot that looked at the feasibility and acceptability. And then I did a pilot randomized control trial. And I'm going to talk to you about the pilot randomized control trial today. So the objective of this, first of all, was to look at the feasibility, acceptability of the research design itself. And that's just to help for planning for future, hopefully a larger trial at some point. And then to look at potential efficacy. So is it effective? Does it have an impact for people following stroke? I wanted to explore their participants' experience of stroke. So I took a qualitative approach as well and interviewed participants and looked at, I wanted to sort of know through the data I was collecting, is it working? And if it's working, how does it work? How are people perceiving that this intervention is working? And I was very fortunate to get funded for this research, so that made it much easier to be able to carry out. Oh. Yeah, study population, okay. So for the, just to go through a bit of the study design then, so for the people that were included in the study, it was their first experience of stroke. And I'm not sure if you use the functional independence measure here, if you're familiar with it, but people had to have at least adequate cognitive and communication abilities to be able to take part in the intervention. It's mostly a verbal type intervention, so they need to be able to engage with the therapist and had to have enough communication and cognitive ability to do that. If they were currently receiving occupational therapy services, then they were excluded. And when I started the study, that wasn't much of a problem. As I went on, new services were added and we had to adapt. But that's just to kind of help determine where the effect of any intervention is coming from. And if people had other sort of significant conditions, they were excluded. Try again. Oh, there we go. So this is the flow through the study. And so the therapists so I was recruiting people when they were done their rehab, either in acute care or had been through the rehab process. So they were being discharged from therapy services, and occupational therapists were screening participants. So they screened 32 people. Of these, 11 either were excluded or were declined to participate. So I ended up with 21 people. And so they randomized 10 to the intervention group, 11 to the control group. And if you see sort of through the flow that everyone stayed in the control group, so I didn't lose anyone there. But unfortunately, in the intervention group, there were 4 people who were lost through the course of the study. 3 of these were really just lost to follow up for various reasons. We couldn't contact them, or they were sick with another illness. And 1 person withdrew from the intervention group, and I'll talk about her later. So these were the demographics, just to give you a sense of the 2 groups and who they were. So age was similar between groups, and probably within you, I mean, probably maybe a bit younger, but not the young stroke group, certainly not the 80-year-old group so much. Discharge FIMs were about the same between groups, but this is, so people that signed up for my study were really, had milder impairments than you might see across the board. So I think these are the people that tend to sign up for research because they have the energy to do that. When we look at time post-stroke, the control group was quite a bit, on average, longer post-stroke, and this was primarily influenced by 1 person who had just a totally different course of rehab and came into our system 3 years post-stroke. And cognitively, they were very similar between groups, and typically not very impaired. So just touching on feasibility and acceptability. So in terms of recruitment rates, it was fairly reasonable recruitment rate for a study, and retention was good, although it didn't balance out. So in the intervention group, retention would be seen as a problem and would need to be considered for future studies. Also looked at treatment fidelity. So the participants, the design was that they would receive 10 interventions or 10 sessions over a 16-week period. And so the average was 8.5 sessions about, and almost 14 weeks on average in terms of the length and duration, but there's some range in there, and it was really based on how they were meeting their goals and how much therapy or how they perceived they needed. Also looked at kind of how the therapists were delivering the intervention and rated their, so we recorded all the sessions and rated them, and found there was about an 80% compliance. The 2 primary outcomes were participation using the Reintegration to Normal Living Index, and this is a scale that measures participant satisfaction with their ability to take part in various activities that would represent participation. So it might be getting around the house, getting around the community, working, leisure, different aspects that could be fit in those initial categories from the World Health Organization. And then the other was goal performance and satisfaction. I used the Canadian Occupational Performance Measure to rate goal performance and satisfaction. And so the projects that people identified, we asked them to rate on a scale of 1 to 10 to rate their performance, so how well they felt they were able to do that activity, and then their satisfaction with their ability to do that. And for analysis, I looked at mean change over time because it was a small group, a small intervention study, and then did a repeated measures analysis of variance to test for any significance. I didn't expect significance because of the number of people in the study, but wanted to look at the effect size that helps to determine if the intervention is effective or not. So this was the scores on the Reintegration to Normal Living Index, so for participation. And if you see, there were different sort of trajectories between the groups. The intervention group started high, took a dip, and then came back up, while the control group started lower and just gradually improved. So really, you can say that based on these findings, that the intervention didn't really have an effect on participation as measured by the Reintegration to Normal Living Index. There is a difference between the groups, but that reflects the difference in trajectory, but it wasn't significant. And I have some ideas about why this happened in the intervention group, but I would need to do more research to really tease that out more. So for the goal performance and satisfaction, what I found was really interesting, both groups improved over time. So if you put both groups together, there was this statistical improvement over time. And so this really, I think, reflects the importance of setting the goals. So both groups set goals with the therapist. And you could see from sort of looking at them that just this act of setting goals actually was an impetus to take action for several people. Between the groups, there was more change in the intervention group. And with the COPM, if you have a change of 2, it's considered clinically significant, so that you can see that performance and satisfaction had that clinically significant improvement in the intervention group, but not in the other group. But just important to think about that just the goal setting itself may be a really important component of interventions. Let's just on. Okay. So the next objective was really to look at their experience of the stroke. And so this is sort of 3 themes that emerged from the qualitative analysis. Primarily, people found the intervention to be helpful. It provided them hope, it was motivating for them, and it also in some ways provided a different perspective. And so this is what a couple people said. It kept me motivated to keep going. And another person said, it got you back in the mood of doing things. So it really helped to get them back to doing things that were important to them. It provided opportunity for insightful reflection. So for some people, it led to reframing. And this occurred for a couple people that when we interviewed them, they reported back that they felt they would have achieved their goals without the intervention. And so I wondered about that because that was their perception. Maybe they were right, and that could well be. So I went back and listened to all their taped sessions, and you could see that the therapist did have an impact on them, but in such a way that the person had felt that they had done it completely on their own, which is kind of the goal of coaching, is to so you can be successful without people realizing that you're helping them. They're really empowered and feeling in control. So that's a nice finding. So a couple people had a desire for a different approach. And this one woman said, and I thought, oh God, I'd rather you have me work on my arm than talk to you about this, but that's all right. So the one woman who felt this way, she stuck through the study and she made some progress on her goals. The other woman dropped out of the study because she was really looking for an expert-driven approach. So it also sort of makes me think that there may be a certain readiness, but I also, when I was listening to those coaching sessions, found that the fidelity wasn't quite up to par yet, so there might have been some room just improvement in terms of the type of support and encouragement that was given. So lots to learn still. So in terms of the components and processes, so those domains of occupational performance coaching and how they were supported through the analysis. So certainly emotional support was found to be quite critical for developing that therapeutic relationship, and probably most of us understand that we need to connect with our clients to be able to give them, to develop that sense of trust and help them feel comfortable taking steps and taking risks to move forward and to help with their motivation. So here's just a couple quotes. She would just would get you going by asking one question. And she made you do all the work, even though it didn't seem like it. And then from the education, the information sharing point of view, when we looked at the data, it really looked like there was sort of 3 main areas where this occurred, and primarily was around really strategies, sharing information related to strategies for goal achievement. But some sharing information related to their stroke and recovery from stroke and helping people to sort of get a sense of that. And then information related to community resources. With regards to goals, and certainly the findings from the COPM reflect the goals, but people really found that the data support that the goals help them to focus, to direct their attention, to help them really persist and follow through on actions. But goal setting wasn't natural for everyone, so it was reflected by this participant who said, I like the goal thing and all that, I would never think of that. I guess I thought it was stupid. And then I realized, no, let's go with this. So some people were a bit hesitant around the goal thing and might have thought, oh, why bother? But they embraced it, and it actually was remarkable what they were able to accomplish.
Do you think it was age-related, Dorothy, that sort of the foreignness of the idea of a goal? And
this fellow was, no, I don't think it was. And actually thinking back on this participant, I would be surprised, because this was a fairly high-level executive type person. So you would have thought that he would be, in his career, would have used goals, but perhaps in daily life didn't apply it the same way. With regards to problem solving then, we found that learning occurred through their testing the plans, and it did lead to new ways of doing. So people came up with their own ways of adapting different approaches to activities. Certainly, the feedback from them, it's not easy. There were challenges. They didn't always go smoothly. But just that trying, it provided them a sense of agency, and they learned through the experience. They also kind of gave feedback that their personal characteristics influenced their approach, and a couple of them certainly described themselves as being stubborn or determined. But one lady described herself as being a rule follower previously. So she had actually been kind of given some rules in rehab that she carried forward, but when she was trying to apply them in different situations, weren't helpful for her. So this process helped her to kind of think in a different way. And people did take what they learned and applied them in new situations. So one quote was, and this was a woman who was a rule follower, "I never thought of that, different ways of doing things before. That was eye-opening for me."
might have warded off dementia for her a little bit.
Perhaps, yes. Different thinking, yes. So just in conclusion then, I really think that occupational performance coaching in occupational therapy, but I think also in rehab, can really offer an approach for applying coaching. And it really help us to be client-centered and focus on what the client really wants. It does show promise for improving sort of performance and satisfaction with goals and helping people to achieve their goals. And certainly the qualitative data supports the components and how it's set up and the processes as working. And really critical is the therapeutic relationship. And the therapeutic relationship, I think, sometimes in clinical practice we get busy and we may not take as much time to listen to and communicate with our clients, but that just reinforcing that, how important that is for helping people move forward. And certainly that goal setting was critical for success. So for me, next steps, what I'm planning to do is I'm here to I feel like the fidelity of the intervention needs to be improved, so I'm going to be taking Fiona's workshop in occupational performance coaching and then working to tailor it a bit more for people for strokes, for therapists who are working with stroke, and go forward and evaluate that. And back in Canada, I have plans to integrate it into their community-based occupational therapy or community-based stroke rehab. So just what I'm hoping you take away, because you may or may not embrace and use coaching in day-to-day practice, but I think there's certain aspects that you can really take away and apply to day-to-day, even certain aspects of it. So really, really listening to the client and trying to get at their goals, and at a truly client-centered level. I think when I remember as a clinician, I would always try to relate my goals to theirs, but they still kind of were my goals. So I think that challenge is to try to step forward and try to get them, focus your therapy on their goals, and it'll be much more powerful. Involve them in the process. So involve them in that problem-solving process. Take an active education approach. So if you give them a recipe, so like the woman who had never thought of a different way of doing, she had been told in rehab that you have to dress your affected side first. She got home and it wasn't working for her, but she didn't think there was another way of doing it. So I think if we're able to engage them in that process, then they versus being given a recipe, they might learn to cook. So think about it in that way. Think about how, when your interactions with clients, how you can build their self-efficacy or their confidence, and through being non-judgmental, through enhancing their experiences of success and developing sort of the challenges that they're going to help them to sort of set their small steps that they're going to achieve. And really acknowledging their knowledge. People come with a wealth of knowledge and a wealth of experiences. They've learned to do problem solving throughout their life, and so they're capable. I think we just need to make them, in some cases, realize it and believe that again. So that's the end of my presentation. Are there questions?
Thanks very much, Dorothy. I would like to, first of all, open it up to the people that are with us remotely. If they have any questions, you can either type it into the chat box or unmute yourself to ask a question. No questions from Southland. Thank you, Southland. Okay, and opening it up to the room here in Christchurch.
So did you have a sort of like a number of weeks that you would be involved with?
So for this, the intervention, I set it out to kind of be, I thought it would be like 10 to 16 weeks, and that would be like 10 sessions over that time to allow, there's always things that come up. So to allow breaks, or sometimes people need a couple of weeks to kind of have more time to work towards their goal or to follow through. But some people were finished earlier, so some people only needed like 6 to 8 sessions, and other people probably would have liked more. And I think we probably see that in practice often. There's some people that, they're ready when we're ready to discharge them, and other people really want to carry on.
We've got one question remotely. First, I'll just throw it there, Dorothy. What methods did you use to help the participants come up with realistic goals within the time frame of the study?
So what I really hope to promote with the therapists who were doing intervention was that not to worry about realistic goals, because we have to believe that people are going to kind of come to an understanding of what's realistic. Certainly if there was a goal that went well beyond the context of the study, we would acknowledge that, but say, within 10 weeks, we're going to see how far we can get, or 10 sessions, we're going to see how far we can get. So I really didn't want to worry about what was realistic, because I also believed that people would learn what was achievable and realistic as they tried things, and they would figure that out for themselves. Yeah, people learn. Sometimes
you have to fail to realize that's where you're going to get to, don't you?
Yeah, and sometimes, yeah, you have to test out, and I think one fellow that took part in the study, he wanted to go fishing, and he had no balance reactions forward and backward. So I can see how, right? It's scary. But he knew he shouldn't be standing on that dock because he might fall right in. But he came up with a way, right? Like the therapist didn't say, "Oh no, you shouldn't be going near the water." He came up with a way, through the process of, deciding to put a chair in his boat, and he crawled across the dock because he really wanted to do it that badly, and he found ways. Yeah.
We've got one comment saying they've got no questions, but thanks for this excellent reminder, reusing the ICF, the International Classification of Functioning Disability and Health. Another question, did you measure the participants' self-efficacy to see if there was any correlation to achieving the goals or not?
So yes, I did measure, so I just presented on a couple of the outcomes, but I did measure self-efficacy, and self-efficacy was for participants was fairly high to start with and was stable across. So this group might have been
which is your typical research population.
yes. Yeah, so they were ready to do it. Yeah.
Can you give us another couple of examples of the goals? Chosen?
So one fellow wanted to go to a baseball game in sort of a city that was about 5 hours away. He wanted to go with his friends, and he had experienced his stroke during heart surgery, so he had the whole endurance piece of it as well that he had to deal with. I'm going to blank now. One woman wanted to, you said the project is declutter her house. She wanted to sort of get her house in better organized. It was, there were papers everywhere and stuff. And so that was her goal, or one of her goals. People had very, very different, one had been thinking about learning Spanish or practicing Spanish for a while and sort of picked that up. So sometimes they were directly related to stroke, and sometimes they were just a bit more life-related goals.
And mainly just one goal that you worked on?
So we tried to get them to identify 3. And some people identified 3, some people just 1. I found that in a more recent study where I've been doing it by telerehab, it's been hard to get people to stretch past 1 or 2. Yeah.
I was interested, you just said you're doing some more by tele research. Did they come into a clinic to see you to set the goals and do their?
So for the telerehab study that I'm just doing the data analysis now on, we did it all remotely. Yeah.
Because that's often a huge barrier. I work in the community, and that's often a huge barrier is actually getting to where people get because they can't drive.
Yeah.
And in New Zealand, we can't drive, people can't get many places at all.
Yes.
Sometimes a bit the same.
Yeah, Canada is very similar. There's a whole remote area out there. Yeah. So this
is a mobile population.
Yeah. So this. Yeah. So this was like for the what I just presented on. We went to them.
Okay.
Yeah. Sorry, I didn't explain that. So we actually went to their homes and did it in home therapy.
Would it be typical in the Canadian community stroke services that are now in place for the service to accept a goal that wasn't directly related to their stroke? It was a life goal they hadn't kind of got around to, and now that you're here, it would be a good time to do it together, sort of thing.
I would think that the therapist would have difficulty picking that up. Yeah. And feeling that it was
lower priority.
That it would be a low priority considering the health system. Yeah.
I was thinking that maybe this approach would be really useful for persons once maybe their rehab had slowed right down, and so they are now looking at some degree of ongoing disability. But now I'm thinking maybe in terms of learning as you're progressing, that would still be useful, wouldn't it? So
yeah, I think so.
Where you are now, and then again as you improve.
Yeah, I think so, and it doesn't preclude improving. And I think, when we think about rehab intensity and trying to get people as active and involved in doing things and doing their therapy, even being involved, right, in those things that are important, your day-to-day activities, that is rehab. So if we can get people more engaged in things they would do day to day, and maybe using their arm, walking, whatever, they will get that intensity more.
Carol would like to know, for further research, have you considered other measures or ways of separating out the value of OPC itself versus only goal setting?
Yeah, so that certainly has been in the forefront of my mind moving forward. We've just been I'm doing some work with a student group, so a very small study that's just looking at goal setting itself. But definitely, and definitely sort of looking at in terms of measuring participation itself, going beyond and having a broader measure. So not just rating the reintegration to normal living, just measure satisfaction or people's how content they are with their abilities, but really looking at what they're actually doing, how they're spending their time. I think those things would be important to add in.
That finding that you had that there was a therapeutic effect from goal setting, that has been found time and time again in multiple studies with multiple populations. And you did say at the start that in your research prior to starting, that goal setting was a known component of many of the successful interventions to date. So there's a sort of, and yet we also know in practice that it's not usual care to set clients into goals in many areas, and so it's a bit of a chicken egg about what's the strategy to bring it into practice versus perhaps separating that out as one component.
Yeah. No, and I think that it has been like, and in stroke rehab, it has been, difficult, I think, for therapists to fully embrace client-centered goals. And there's certainly a number of, you have your job to do, and there can be organizational or institutional constraints around sort of what you're able to do. So I think that challenge still exists. Yeah.
We have one final gnarly question from PMH, who would like to, who say, our services see many return clients that have very low self-efficacy and may struggle to set goals, such as have been excluded in your study. Any suggestions to help with this group?
I think that starting by building that therapeutic relationship, that's going to help to really connect with them and start to get them thinking about what their goals are, maybe as a starting point. It is a tough group when you have a really low self-efficacy, and I would really like to have been able to tap into that group in my research, because I think that those are probably the people that need it the most. I sort of feel that those that are doing well and have high self-efficacy, they're going to do well probably anyways. So nothing maybe too concrete at this point, but I think there's a way to sort of meet them at their level and build their self-efficacy through just small steps.
And I think your personal projects aspect that you brought into it is a really good way to capitulate people away from thinking about the goals of their body parts and all the things that they don't have right now that they just used to have quite recently, to your vision for the future.
Yeah.
Your future self.
Yeah, I was thinking of that in relation to insight. If they don't have the insight into their own difficulties, that actually going off on a tangent to think of what we might see as a separate life goal or something just that they're interested in that doesn't have the direct relevance to their stroke impairments, that you can almost kind of disguise the goal that way, and then the therapy can still work on their impairments even if they've not recognized them.
Right. Yeah.
It's because they've picked something else.
Right. Yeah.
Because it's within the teaching of the method and so on, but how do you know you've got to the goal that'll turn their lights on? That'll keep them motivated.
It soon becomes apparent, and
I understand. But
Yeah.
Yeah, I mean.
Yeah, I think.
Lots of things.
Yeah. So getting them to. When I did the, I didn't go a lot into detail about personal project analysis, but part of it is having people rate different aspects of their goals. So you can rate them, and I don't think it would take a lot of time to do this clinically, but they rate what they perceive as the challenge of the goal. They can rate what they perceive as support from others. So you can rate what they choose on different dimensions, and that might give you some insight into how motivated they're going to be for that. But what I found, for the most part, people were pretty motivated. What they chose, they wanted to work on.
in terms of identifying the importance that was ridiculously sensitive. Goals, there is an addition to the COPM around rating how important is this goal to you on a scale of 1 to 10, or the big, so sometimes people do that.
Yeah.
I'm not entirely sure if everyone remote can still hear us through my computer or not. people are starting to leave. But thank you very much, Dorothy, and thank you for doing 24 hours of flying for There are a couple of places left on the one-day introductory workshop to occupational performance coaching. It's on tomorrow, so if you feel sicky, arrange to leave. We'd love to have a few people working in adult neuro attending. It's in this room at 8:30 tomorrow.
Good plug.